I think we'll continue on the same theme as the last case. First talk is a recording by Dr. Greg Stone, so can we please bring it up? And I should welcome all the panelists and audience. Please feel free to ask questions as well.
Can we start the first presentation, please?
Hello, this is Greg Stone from the Mount Sinai Healthcare System in New York City. It's a pleasure to be with you today remotely to discuss with you the 5-year final results from the COAPT trial of the MitraClip in patients with secondary mitral regurgitation and heart failure. I really love coming to the TCTAP meeting. I wish I could be with you this year, hopefully in the near future. But in the meantime, it's great to be with you remote to be able to share these results. These are my relevant disclosures in mitral valve space. So you all are familiar with the COAPT trial. This is actually the largest randomized trial to date in the patients with mitral regurgitation of any sort. And in this trial, which was a parallel controlled, open label, multi-center trial, we took 614 patients with heart failure and moderate to severe, that is 3+, or severe, that is 4+, secondary mitral regurgitation, who remain symptomatic despite maximally tolerated guideline-directed medical therapy. And we know that patients who develop heart failure, who get left ventricular dilatation and then mitral leaflet tethering because of papillary muscle dislocation, and then they develop severe MR, we know they have a worse prognosis. But since the disease is the underlying left ventricular dysfunction, we never knew whether treating that would be able to improve the prognosis of patients without treating the underlying abnormal left ventricle. So to test this therapy, we randomized 614 patients with severe secondary MR to maintain on their guideline-directed medical therapy alone and then either be treated with the MitraClip or just control. And we previously reported the 2-year results and published this in the New England Journal, and we recently just reported the 5-year results and again published them in the New England Journal. And the 2-year results has shown that the primary endpoint of all heart failure hospitalizations were markedly reduced with the MitraClip treatment by about 50%. And when we follow the patients now for 5 years, you can see there still is about a 50% reduction in all heart failure hospitalizations. So in the patients treated with medical therapy alone, there were 447 hospitalizations in 208 patients, about 2 per patient. Patients who were treated with MitraClip alone, it was 314 heart failure hospitalizations in 151 patients. So the average was reduced from 57% per year to 33% per year, overall a 47% reduction in the hazard, which of course was highly statistically significant. Now we had a primary safety outcome, which was a composite as requested by the FDA of device-specific events and then progressive heart failure requiring either an LVAD or a heart transplant. And this was measured at 1 year. And at 1 year, we just had to be below 12%, and we were at 3.3%. And there were only 4 events that were related to the MitraClip, 1.4%. And as everybody knows, this is one of the safest procedures that we do in the cath lab. We now have carried that same analysis out to 1 year. And while, yes, there are some patients who have progressive heart failure, as you can see, the device-specific events are only 4. So all of them occur within 30 days. There were not a single abnormal safety event related to the MitraClip, including a single leaflet device attachment, embolization, endocarditis, severe mitral stenosis requiring surgery, or any other device-related complication requiring surgery in the MitraClip group. Now, if you look at the composite of death or heart failure hospitalization, you could see that there was a 47% reduction with the MitraClip at 5 years compared to medical therapy alone. And when we looked at all the pre-specified subgroups, young versus old patients, men versus women, low surgical risk versus high surgical risk, large versus smaller left ventricles, et cetera, we saw very consistent results in all of the patients studied. If we looked at just the time to first heart failure hospitalization, you could see there was a 51% reduction. This is your standard time to first event Kaplan-Meier curves. So from 83% down to 61%. When we do a landmark analysis, we could see that really most of that benefit was in the first 3 years. The curves kept diverging for 3 years. Then after 3 years, there was no significant difference in a first heart failure hospitalization between the two groups. Maybe a weak trend favoring the MitraClip, but not significant. If we look at all-cause mortality, there was a significant reduction in all-cause mortality, an absolute 10% reduction. Number needed to treat about 10 patients to save one life at 5 years. Overall, a 28% relative reduction, highly statistically significant at 5 years. But again, looking at a landmark analysis here, the mortality reduction was really mostly within 2 years. And between 2 years and 5 years, we didn't see much difference. So why was the effect of the MitraClip, the beneficial effects, mostly limited to the first 2 to 3 years? And the real reason is that in this trial, we allowed crossovers from the control group to be treated with the MitraClip at 2 years. So we did not allow patients to be treated with the MitraClip in the control group before 2 years, but at 2 years, those patients who had survived up to that point and still had severe mitral regurgitation and otherwise met all the criteria for the MitraClip could then be given the device, paid for by the study, and receive the MitraClip. And as you can see, at 2 years, about 44.9% of patients who were eligible, who survived to 2 years were treated with the MitraClip at 2 years. So there was a substantial crossover rate. Now, importantly, about half the patients had died before 2 years. So a lot of patients weren't, around to take advantage of that crossover, but of the ones who were, 44.9% did. So altogether, there were 21.5% crossovers in the entire study population. And this curve shows the impact of crossovers. What you have here in green is patients randomized to MitraClip. In blue is the patients randomized to the control arm of medical therapy alone, censored at the time of a crossover. So their data was removed after they crossed over. And then they're put into the gold curve. So the gold curve is the original medical therapy group who then crossed over. And now there is a variable time of crossover, anytime within this 5 years. So the time of crossover was set back to 0, regardless of when they crossed over. And you could see that from the time of crossover, patients in the control group basically assume the death and heart failure hospitalization rate of the originally assigned MitraClip group. And if you look at the medical therapy group alone, and if you perform a time-adjusted multivariable analysis, taking into the timing of crossover, crossing over in the medical therapy alone group was associated with a subsequent 47% reduction in death or heart failure hospitalization, almost identical to what we saw from the initial randomization. This held true for heart failure hospitalizations alone. You'll note the crossover group directly assumes the event rates of the MitraClip group, and it was also true for mortality. And all of this was predicated on and, was benefited by the marked reduction in mitral regurgitation severity. At every time period, there was less MR severity in the MitraClip treated group. And so the MitraClip group all the way through 5 years is on the left, the medical therapy alone group all the way 5 years is on the right. In the MitraClip group, you could see, I just have highlighted in the boxes, the percentage of patients that had recurrent severe 3 to 4 plus MR, and it was low single digits at every time period. In contrast, of course, a lot more patients had 3 to 4 plus MR in the control group. You could see there's less over time, and that's because those patients who maintain 3 to 4 plus MR are dying over time. So that's survival bias. So what do we conclude from the 5-year results from COAPT? In patients with heart failure and severe secondary MR who remain symptomatic despite optimal medical therapy, transcatheter edge-to-edge repair with the MitraClip was safe, reduced the rate of heart failure hospitalizations, and improved survival during 5-year follow-up. These outcomes were consistent across all pre-specified subgroups, regardless of patient age, sex, MR severity, LV function and volume, cardiomyopathy, etiology, and surgical risk. The symptomatic status, NYHA class, was also improved throughout the 5-year follow-up, and the MitraClip treatment provided a durable repair of MR without recurrence. The treatment effects were reduced after 2 to 3 years in the trial, in large part due to MitraClip treatment in 45% of control group patients who survived to 2 years. The prognosis of control group patients so treated was substantially improved, similar to that of patients originally assigned to MitraClip treatment. However, nearly half of control group patients had died before becoming eligible for crossover at 2 years. Heart failure patients appropriate for transcatheter edge-to-edge repair with the MitraClip should therefore be identified and considered for treatment as early as possible. And I think that's a really important secondary implication of this study. Waiting until the patients, get out to several years is futile because a lot of them are going to die every single year, and you can prevent a lot of those deaths and a lot of the heart failure hospitalizations by identifying the appropriate patients for MitraClip treatment despite optimal guideline-directed medical therapy as soon as possible. But we were also honest in pointing out that despite the favorable risk-benefit profile of the MitraClip in this setting, adverse outcomes continue to accrue in both groups, and even 73.6% of MitraClip-treated patients had either died or been hospitalized for heart failure within 5 years. And this study really, therefore, points out the need for further therapies to address the underlying LV dysfunction in this high-risk population. So we certainly can mitigate and improve their prognosis by treating the secondary mitral regurgitation, but we now have to work on treating primary left ventricular dysfunction, preventing heart failure, and then treating it when it occurs. And of course, there are numerous therapies that are under investigation for this. So thank you very much. It's been my honor to present the 5-year results from the COAPT trial.
The next speaker is Dr. Kim.
Good morning, ladies and gentlemen. This is Dae-Hee Kim from Arthur Medical Center. I'm imaging specialist. I have nothing to disclose. The transcatheter puncture is the most important step in TEER procedure. Usually, in most of cases, and superior and posterior puncture is preferable. Biplane imaging is a basic tool for septal puncture. Usual stable septal puncture height 4.0 to 0.5. It depends on the location of region and depends on etiology. But we have to emphasize that the 3D identification of the puncture size is very important. In this case, you can clearly see the tenting location after guide wire in and catheter in. We have to check the location of the septal puncture site. Slightly posterior from the commissure is preferable for catheter management. However, in patients at very severe arterial functional MR, where if we try posterior and superior puncture, usually septal puncture is greater than 10 centimeter or 9 centimeter. In this case, we get 4.5 stress septal puncture height. Anterior puncture cannot be avoidable. After that, the catheter management is very challenging and difficult. To identify the CLEP location in 3D unfast view is very important. But the perpendicular plane is the coaptation line. According to the coaptation line, you have to identify the perpendicularity of the clip itself. In this case, very easy. The 90 degree rotated from the coaptation line. But the problem is in usual case, in normal mitral annulus is ellipsoidal shape, but in patient with hugely dilated left atrium, the annulus shape becomes circular. The severity index calculates the ratio between intercommissural distance and AP diameter, and usual index was 0.8. In patient with hugely dilated left atrium, the annulus becomes circular, but especially in lesion located in commissure, very difficult to identify perpendicularity in these cases. Let's check the 3D location. We are trying to pit pulse region with XTW clip, the largest clip, the mitral clip. The problem is what's going on in this patient. The posterior riblet is not well on the posterior arm of the mitral clip. At this moment, we have to check the 3D location, slightly rotate counterclockwise. We have to rotate slight clockwise. After that, we grasp well both riblet and insulated. Yeah. Another important thing is we have to get a true bicommissure plane. As you can see here, you can clearly identify both papillomas in this view. After then, you are applying plane imaging, and you can get elevation view like this. In most of the cases, especially central region and the central medial region, you can clearly see using biplane imaging, the both gripper is down and both replane insertion can be identified with biplane imaging. However, in this case, we are trying to AU1 porous region, a closed lateral commissure, but the problem is we can get a clear image in biplane imaging, but we cannot identify both gripper are down or both clip arm in this image. At this point, we have converted to single plane imaging strategy. At this moment, we can clearly see both arm and leaflet gripper are down, and then we can clearly see the leaflet insertion both anterior arm and posterior arm. After that, we can check the clip insertion in deep gastric imaging and single plane like this. Let me show another case example from our center. This is an 8-year-old male showing a typical P3 porous in caudal rupture involvement in medial commissure. We have to check pulmonary vein to check the pulmonary reversal. Interestingly, this patient shows no pulmonary reversal, right lower pulmonary vein, right upper pulmonary vein. Only pulmonary vein reversal shown in left upper pulmonary vein. Especially in patient with eccentric degenerative MR, we have to check all pulmonary veins like this. Only one pulmonary vein was reversed. Let me show another case example from our center showing ventricular functional MR, diffuse MR jet from interior coaptation line. We have deployed 2 MitraClip in this patient. We are trying to apply first clip with XTW. Yeah, after deployment of first clip, XTW, we can clearly identify both MR jet between both MR jet, lateral and the medial side of the first clip. We have to check pulmonary vein, right pulmonary vein reverse disappears. But the problem is the systolic is diastolic dominant wave. We have to stop the procedure, or we have to put another clip. We decide to put another clip at the lateral side of this first clip. We deploy second clip right here, just mild MR between 2 clips. In 3D imaging, alignment of 2 clips is excellent, and only mild MR seen in between the clip. Interestingly, right pulmonary vein reversal disappear after disappearance, and the diastolic dominant wave after second clip appliance. We have to check normalization of pulmonary flow like this, systolic dominant flow wave. Immediate post-procedural transthoracic echo, we identified just mild MR between the 2 clips. Pulmonary vein flow checking is very important procedure to MitraClip guidance. Disappearance of pulmonary vein reversal. Besides, we have checked the S-way velocity and the increase in the S velocity. The ratio between S and D velocity ratio is very important. This is a paper published in 2009 JAG Imaging, but the independent practice for 2 years survival was a pulmonary vein assessment is very important. Change in S-way velocity, the change in SD velocity ratio, improvement in pulmonary waveform, including disappearance of pulmonary reversal, independent practice for 2 years survival. Also, all-cause mortality and composite endpoint, pulmonary vein assessment is very important to predicting prognostic outcomes. Let me summarize my talk of today. Septal puncture. Usual septal puncture is superior and posterior, but the 3D identification of the puncture site is very important. Posterior puncture is preferred for management of catheter delivery system, but sometimes anterior puncture cannot be avoidable even in patients with a hugely dilated left atrium. Clip orientation always has to be checked with the 3D imaging. Slight rotation or counter or clockwise rotation have difficulty in grasp both leaflet insertion. Biopaging is very important for the clip grasping, but in usual case, But sometimes in commissural region, especially in the lateral commissural region, compared to single plane strategy very helpful. I also would like to emphasize the pulmonary liberation in patients with eccentric degenerative MR. Only one pulmonary vein can be reversed, and then we have to check all 4 pulmonary veins. And then we have to check pulmonary waveform change, even disappearance of a pulmonary vein reversal, increase in S-wave burst, and normalization of pulmonary wave pattern is very important. Thank you for your attention.
Great presentation. I think we'll move on to the next presentation because we are running out of time. So Dr. Leon is going to talk about the Apollo trial.
Dear colleagues, thank you for allowing me to share my experiences with the Apollo Intrepid TMVR trial on behalf of all the Apollo and Intrepid investigators. These are my disclosures. First, the Intrepid TMVR technology is well known to many of you. The valve has an inner stent with a 27mm tri-leaflet bovine pericardial valve, and a conformable outside stent anchors with the geometry. It's a symmetrical design with predictable and controlled valve deployment with both transapical and transfemoral delivery systems in sizes that are 42, 48, and in development 54 millimeters in diameter. The Intrepid TMVR clinical program occurs in many different phases, beginning as early as 2014 with a pilot study of first-generation transapical devices. I'd like to combine this with the initial randomized trial roll-in patients of the first-generation transapical device that was brought to the United States in the initial U.S. studies. These studies were performed in 2014 to 2020. So this phase 1 experience includes 208 patients with a transapical delivery system that has a unique hydraulic mechanism for capsule movement in very simplified procedural steps, including high and extreme risk patients. The data on these 208 patients included a 1-year all-cause mortality of 27%, with a fairly high rate of reoperation or reintervention, largely due to bleeding or tamponade, a high rate of heart failure hospitalizations, strokes, and bleeding events. This shows you the all-cause mortality out to 2 years from this 208 patient study. There were many learnings from this phase 1 experience. Certainly, there were a high screen failure rate, largely due to the risk of LV outflow tract obstruction, annulus sizes that were too large to the accommodating devices, sometimes LV volume size too large or too small. At times, prohibitive MAC was also an exclusion criteria. We learned that the deployment was highly predictable and that MR reduction at a month was dramatic, with all patients having none trace or only mild MR after the procedure. We also learned that the valve function was stable with MR reduction persisting over the course of 3 years in this analysis of 95 patients with a paired analysis of 43 patients out to 3 years, showing that there was retention of the excellent reduction in residual mitral regurgitation after this TMVR implantation. The second phase of the study was the development of a recoverable transapical device, but during that time, there was additional work with mitral edge-to-edge repair. That was an important consideration in terms of being able to treat patients in the United States. We observed that surgeons were not amenable to randomizing open surgery to transapical TMVR, and that early bleeding complications with the transapical device provoked acceleration of the TF-TMVR program, which has led to the phase 2 learning experience, which has evolved into an aggressive assessment using a multidisciplinary heart team with a primary cohort of patients who are not surgical candidates and a second cohort of patients that had MAC who could be treated, we believe, with the TMVR system. This interesting evolution to patients in the MAC cohort was demonstrated by a variety of specific case anecdotes evolving into what is a registration trial in the United States. Here shown is an example. So we are now enrolling in the single-arm transapical and transfemoral portion of the Apollo trial that allows us to be able to enroll patients that are not surgical candidates and also not candidates for mitral edge-to-edge repair. We have integrated the Intrepid TMVR transfemoral system as shown here, which is in its current formulation is a 35 French device. The initial results from the early feasibility study of the transfemoral Intrepid system, as shown here, shows again excellent reduction in mitral regurgitation, marked improvement from the standpoint of symptoms and patient-reported outcomes, and a dramatic reduction in the frequency of early complications, as was seen in the transapical experience. Thus far, there have been over 350 Intrepid valve implants. We have as long as 6-year follow-up patient outcomes in the early experience, and more than 50 patients that have been treated with the transfemoral device. In the future, we are beginning an Apollo EU single-arm study and planning a randomized trial to expand clinical indications. The next generation transfemoral system, which will be the commercial system in the United States, will include the large size with a lower profile Intrepid 29 French delivery system. So final thoughts in this Intrepid valve journey include, during the past 8 years of the Intrepid TMVR experience, over 350 implants have been performed. There's been an evolution of device technology, peri-procedural learnings, and clinical trial activities. Importantly, a dedicated global infrastructure has been cultivated, including operators, investigators, clinical sites, engineers, and clinical research staff to execute this clinical development program. Currently, the major focus is enrollment of the single-arm Apollo study, initially TA and now transfemoral, in high-risk patients unsuitable for surgery or TEER therapies. And further studies will determine if Intrepid TMVR has broader applications in mitral valve disease therapy.
Thank you. I think we can spend 2-3 minutes on the discussion. So maybe anybody from the panel has anything to ask the question?
Question for Dr. Stone. In COAPT trial, death or heart failure hospitalization reached 74% within 5 years. In your perspective, is there any subgroup of patients benefit most from TEER therapy?
I think Dr. Stone is not here, so I can answer it for the COAPT trial thing. So when you look at the mortality at 5 years, what are the most important predictors of mortality at 5 years? That's what I think the question you are asking. And LV function in the pressure, LV diastolic dysfunction, meaning the systolic and diastolic, because if people were in higher LV function dysfunction, or people who had RV dysfunction, these were the patients who did worse in the group. So ultimate cause of death or cause of mortality and hospitalization was LV function-related events rather than MR-related events. So there's no recurrence of MR, but people were dying from LV dysfunction. So earlier treatment may be the message to say that if we can identify the patients early for treatment, we may be able to have better outcomes.
Samir, and there's TVT data on MitraClip post-COAPT, and have you seen similar trend, or is it worse or better in terms of results?
So in the advanced registry, of course, the results are a little bit better, but again, is it because of different population of patients treated in this group? Because now we are treating patients a little bit earlier, LV dysfunction is not as bad, and the medical therapy also has gotten better.
Yeah.
So these are the three reasons why I think the outcomes are a little bit better. And the tricuspid therapies are now available, so this is also something to keep in mind, that people who have mitral therapies, and if they have tricuspid valve disease, then they have more therapies for that. And this leads to our second discussion of tricuspid valve. But anyway, any other questions?
Thank you, Dr. Kapadia. You said, and as mentioned, Dr. Stone, the TEER procedure as soon as possible will improve the patient's survival. If that time, how is the optimal duration of GDMT? 1 month or 3 months, what is optimal duration? And second question is, we cannot prescribe the GDMT for drugs, such as low BP or low heart rate. When we met that patient, when we performed the TEER procedure?
Very good question. So I think the heart failure consultation is very important. And what we are recommending now is that 30 days trial is necessary to make sure that reassess them after 30 days of maximal medical therapy. And you're right that many patients cannot tolerate all 4 pillars of heart failure therapy. So whatever the best we can do is the idea. Now, there is a new trial in design for the moderate mitral regurgitation with MitraClip in the COAPT kind of population. So not to wait until they have severe mitral regurgitation. And this is something that is going to be exciting. There is a trial with a carry-on device where people with symptoms who have mild or moderate mitral regurgitation are also randomized. So this is called EMPOWER trial. So there is a lot of effort going on to treat the patients earlier with mitral regurgitation in heart failure population.
I think one more comment is Dr. Kim's talk on echo. I think echo is an important ingredient of this procedure. And to get a good imager and work with them regularly is going to be very critical for success as well. So when you build a team and learning curve, preferably work with a dedicated imager.
Absolutely necessary, yeah. Without you seeing, it's like a surgery. If you don't have a good exposure, you cannot operate. So this is the same way, if you cannot see what you're doing, it is a terrible idea to do the clip.
I think just one comment to the COAPT trial, the 5-year result, I think is excellent. I'm very excited to see the effect of the MitraClip maintained throughout 5 years. But the one message behind would be there's still more than 70% of patients having adverse events. So there's actually much things we need to do in addition to the MitraClip. Although we have to do MitraClip early, but we still have much thing to do for the GDMT. Maybe, especially in that trial, that the percentage of patients receiving ARNI, SGLT2 inhibitors are minimal. Yeah, were minimal. So, yeah. Maybe we have to do a lot.
This is what I'm saying, is that now the improvement has happened because of these 2 very important advances compared to the COAPT trial. So very good points here.
I think we should move on to the next session. The next session is on tricuspid. So we'll start with a talk on catheter-based strategies for TR.
Thank you. Good morning. I'm going to talk about some of the TR developments. I'm involved in a few of the trials. So functional TR is very serious disease. It has mortality that's similar to aortic stenosis, and it can progress rather rapidly over 5 years. You can go from mild to severe. Surgery historically has not been something that's been used to treat this problem. From the STS database, we see that the operative mortality is fairly high in morbidity, and the number of cases, at least in the United States, is historically very low. Part of the emergence of this field has led to a reclassification of severity into, instead of 3 eyeball grades into very quantitative 5-grade system, helped developed by Becky Hahn, from mild, moderate, severe, massive, and torrential to really characterize the degree of TR better. Here's a cartoon of the anatomy. Typical anatomy is 3 cell-like leaflets with 3 papillary muscles. Important structures include the right coronary artery and the AV node close by. But really, there's a lot of variability in the tricuspid valve anatomy. Classic anatomy is only seen about half of the time, and a lot of times you have 4, maybe 5 leaflets or divided leaflets. There's dozens of devices, as we've seen in previous lectures, and many are already gone. So far, the ones that have been studied most are the TER devices, the valve replacement, and annuloplasty, and then there's what I call no options, spacers, and cable devices I'm really not going to talk about. So I'm going to show a few cases. 61-year-old gentleman after a transplant had posterior septal fail, probably from biopsies. You can see it here. Torrential TR, good leaflet length, narrow gap, annulus was mildly dilated. The choice here was TEER with a Pascal device, and a single device led to really no more than mild TR. The leader in this space was first the triluminate, the MitraClip in the TR space, and early experience showed adequate reduction, usually to moderate or less, not quite complete elimination of the tricuspid regurgitation, but that correlated with symptomatic improvement in the early experience. And similarly, the Pascal device showed decent reduction, typically moderate or less, and symptomatic improvement with TEER. This led to the recent presentation and publication of the triluminate experience with 350 patients randomized to TEER with the TriClip versus medical therapy alone, and looking at a large composite outcome of death, TV surgery, heart failure hospitalization, or change in quality of life. At 30 days, there was substantial reduction with TEER and the amount of MR. Most got to moderate or less, and this is sustained for a year. The trial was positive, but really it was all driven by quality of life. And you can see that the less TR you had, or the greater the reduction, the better you felt. But it didn't meet kind of hard outcomes in terms of mortality or hospitalization. So is this a win? Was it too selective? About half the patients screen failed. There was no sham arm, so you have to worry about a placebo or even a Hawthorne effect of being watched. And there was only 1 year of follow-up in this publication. They're going to plan to follow these patients for 5 years. Similarly, the Pascal device has been followed for a year, at least in preliminary studies, and it's ongoing. And it has similar sustained reductions in TR and improvements in quality of life. So I'm going to show a different case, 75-year-old with persistent AFib, severe annular dilatation, massive TR, short restrictive leaflets, so not a good TEER candidate. The choice here was valve replacement. And here you can see the evoke valve fluoroscopically, and here's after the implant, really no residual regurgitation. Here's the early experience with the evoke system after 1 year. You can show substantial reduction, and as opposed to TEER, 90+% of patients are mild or less TR. There is a small amount of pacemaker risk, given that AV node that's close by here. It was 7% within 30 days. Here's the TRISCEND Global Registry, about 175 patients, very high implant success, excellent reduction in TR, excellent improvement in quality of life. In the TRISCEND 2 trial, 250 patients randomized 2-to-1, valve versus optimal medical therapy alone, and followed through 5 years. Enrollment was just complete. So we'll have pivotal information on valve replacement. So third case, 71-year-old woman, massive annular dilation, severe massive TR, large coaptation gap. Here you can see just massive TR. The choice here was annuloplasty, and here you can see with the cardioband, there's a wire in the right coronary artery as it's adjacent to the valve, and you don't want to crimp it. These are meticulously placed anchors, 17 or so, with TE guidance, sometimes 4D ICE guidance. You get them in a semicircle and then cinch them all together. And here you can see, I think this was 30 days, but reduced from massive to moderate. And here's the early experience with the cardioband system. You can see that you get more modest reductions in the TR. Again, some that are still severe even after 30 days, but over time what's interesting is the annulus continues to shrink, and whereas about 55% were moderate or less at 30 days, that went up to 73%. So there is some gains over time with the cardioband. Now the caution on this is a very long, sometimes very difficult procedure as opposed to the first two options. So I want to answer questions about TB therapies. What's the appropriate trial outcome? We saw that in Triluminate, it was mostly quality of life that drove the outcome. And should there be shams? There was no sham. Are the promising results durable? Anticoagulation is a key factor for valve replacement. How long is it going to be required? And does TER preclude future therapies on the valve? Should we be treating TR earlier? I think Dr. Kapadia indicated that in the mitral space. Are we waiting too long? Are we waiting until they have liver and renal failure? And on a broader scale, should be more aggressive about treating AFib pulmonary hypertension earlier to prevent the TR from happening and stop placing pacemakers across the tricuspid apparatus that leads to a lot of this tricuspid regurgitation. So final case, here's a patient that had TER and had a SLDA. You can see the device here just flapping away in the posterior leaflet, completely detached from the septal. So the choice here was to put a valve over this. And here you can see afterwards there's really no residual TR, and the Pascal device in this case is locked in place by the frame of, in this case, the evoke valve. So our potential solutions for failure of TER. So in conclusion, tricuspid regurgitation portends a poor prognosis. Surgical therapy is uncommon and associated with poor outcomes. There's an array of devices that emerged that have shown promise in the treatment of TR and RV failure. And there's a lot of unanswered questions that hopefully the ongoing trials will help answer.
So we'll move on to the talk on imaging. I think as in mitral, tricuspid imaging is more critical. It's a valve which is really hard to see sometimes. Dr. Chen.
Thank you, and thank you, Vivian. Thank you for having me in TCTAP to present the imaging for transcatheter tricuspid valve intervention. Given that the requirement for imaging would be very different, but it depends on which technology you use for the therapy for mitral tricuspid valve replacement or annuloplasty or edge-to-edge repair. Given that the edge-to-edge repair is most available devices and probably the only available device in Asia, so I would base on the image to discuss what are the essential TE images for the tricuspid intervention. This is a very nice data published from Bern to propose the tricuspid TR scoring system that the patient with high score would have less successful rate. And from the image, from the scoring, you can understand what are the essential image. The first is the tricuspid and fast view, which would demonstrate the deep depth numbers and also morphology. Although we know the type 1 and type 3B are the most common predominant morphology, but from the trigastric and fast view, you can nicely see the deep depth number and morphology, and also you can identify the jet location, whether it is at anterior septal or septal posterior, which would be more easier. If the jet is located only at the anterior posterior, that would be very complex. And also from the jet, you can understand the jet morphology and to decide which stretch would you do for this patient. You can do the bicuspidization, you can do the Karl technique. And the other image is the RV inflow view, which can show in the septal anterior or septal posterior leaflet, and you can measure the septal lateral leaflet gap and to identify, to realize the diff complexity. And also you can also observe the septal leaflet mobilization. If the leaflet is very tethered, and that would be very difficult to use the TEER to treat the patient. So the MFACE view could be obtained from the transgastric view from 14 to 90 degree. And from the transgastric view, the very nice images that you can demonstrate all the leaflet edge on the single view. And then on the right-hand side is the septum, and then you can identify the aorta, and between the septum and aorta would be the septal anterior commissure. From that, you can also identify the septal leaflet. And also you can further understand the popliteal muscle. The anterior popliteal muscle is the most prominent popliteal muscle in the right ventricle, and you can divide it by anterior leaflet and also posterior leaflet. And how to get the optimal images that you can have a transgastric long longitudinal view of the right ventricle, and therefore you do the S-plane on the annulus, and then you can have very nice transgastric and face view. And then you put on the color, you identify jet location, and then you will decide your treatment technology strategy by edge-to-edge repair, either with anterior septal, posterior septal, Clover technique, or by hospitalization. So the morphology of the tricuspid annulus is very important from the transgastric view. You can, from the view, this is the only view you can precisely orient your clip to do the clipping. So for these type 3C images, if you have a very large gap opening on the central, if you do the septal 1 to anterior, septal 2 to posterior, you can realize that you probably will left a central significant residual jet. And therefore, you probably have to go by Clover technique. You have to clip on septal 1 and to the posterior. From the type 3A is the same. You clip on a septal anterior, a septal posterior. Actually, the remain a gap between A2 and also septal. You would definitely leave the very significant jet at the central. So maybe you can put on a single clip at A2 to the septum. So the MFACE view also give us the general concept about how much the clip number we would need, and especially the clip orientation. And also, you can confirm our leaflet grasping. This is especially for patients with mitral prosthesis, which may give very large shadow on the RV inflow view to blunt your leaflet, checking on the leaflet insertion. So from this case, you nicely show from the transgastric view, nicely demonstrate the leaflet edge, and you can realize the patient have very large gap between the septal and also the P1. From the transgastric, you can orient your clip to very perpendicular to the coaptation. And also by the X-plane on the junction between the leaflet and also the clip from the longitudinal view, you can also identify the limit motion of the leaflet, and to confirm the leaflet has been sitting on the clip arm. And also you close the clip, and then you can eyeball the leaflet inside to the clip, and then you orient the second clip, and then the third clip, and you can finally get a good Clover technique to reduce the MR2 from torrential to mild. And the other view is the transesophageal view, either a middle or lower transesophageal view. And from that view, you can also identify the popliteal muscle. It would be very easy. And leaflet close to the aorta is the anterior, and the other side is the posterior. You can have the septal leaflet close to the probe. So therefore, you explain on the septal anterior, you get the septal anterior on the RV field view. From the view, we can identify the leaflet mobilization and also the gap. And you explain on the posterior, you will get septal and posterior view. So from that, you can decide which clip would you prefer to do the first clipping. And also from the view, for RV field view is similar to what we have when you have MitraClip experience. This is very simple to the longitudinal view. You can easily advance your device, and also you can identify the leaflet insertion from this view. However, if the patient has mitral prosthesis, the view would not be work for that. The 3D view is fantastic, and also you can identify the leaflet morphology as what we have done from the transgastric and face view. However, the perpendicular orientation might not be precisely to be done by the 3D and fast view. But the 3D image, especially by using the multi-plane reconstruction view, you can easily to identify not only the leaflet morphology, and by orient the plane, you can understand the septal anterior. If you plan to do the clipping, you can check the leaflet morphology, and then if you do the septal posterior, you can also check the leaflet morphology from here to identify the treating plan, especially you can use this in multi-plane reconstruction image during the procedure. So this is a conclusion. The transcatheter view of tricuspid valve is essential to evaluate the leaflet morphology and geolocation for the TIA strategy and clip orientation. The mid-esophageal view demonstrates the leaflet length and mobility, and the grasping gap to evaluate feasibility using TIA technology to treat a TR. The multi-view of 3D images are very useful for not only pre-TE image. If the image quality is good enough, it can also be used during the procedure. Thank you for listening.
Thank you. I think we'll go to the last presentation of tricuspid regurgitation repair versus replacement by Dr. Vinny Bapat.
Thank you, Samir. Great talks ahead. And continuing on the same theme, there are multiple technologies available for repair and replacement. And broadly, you can define them as annuloplasty devices, leaflet devices, stented valves, which are not in the tricuspid, but in IVC, SVC, and of course, orthotopic valve replacements. I think if you just look at the comparison between mitral and tricuspid to understand what things are going to work and what not, we have TEER, which has worked well in mitral. We have annuloplasty devices, which didn't work very well in mitral. TMVR has worked well. It's since 10 years, around 1,200 cases only. And in mitral, there are only two etiologies, technically, primary, secondary. But in tricuspid, we also get additional problems such as pacing lead-induced TR, which poses its own challenges, and again, management of the patients as well. It's important to understand when we discuss tricuspid, the anatomy, and this is how it looks like. But this comes into play when we are deciding which technology to use. For example, if you think about repair technologies, leaflet-based technologies, TEER devices, the leaflets of tricuspid are extremely thin. And as very nicely shown on the talk on the imaging, the leaflets can be many and multiple folds. So unlike the mitral, where it's only anterior and posterior, we may have to deal with up to 7 leaflet segments. Imaging can be harder, especially if the patient has, say, a mitral mechanical valve or any other device, and of course, if the heart is enlarged and distorted. And more importantly, as you saw in the earlier talk on triluminate trial, it's very hard to decide about the outcomes because torrential TR going down to severe TR, does it really make an impact? And in certain technologies, actually, it is extremely difficult to define the effective regurgitant orifice area because the valve's distorted after particular treatment. So these are multiple challenges we are going to face when we assess the impact of tricuspid repair devices. The annular devices have not worked really well. I think we saw a nice example of cardioband in tricuspid. The annulus in the tricuspid is ill-defined and also more delicate. And one of the things when the cardioband was used from mitral to tricuspid, we realized that the length of the band is much shorter because tricuspid annulus can be really large. This is just one of my cases where I've done a surgical tricuspid repair. I always wonder how I get away by not damaging the right coronary. But you can see that the right coronary artery can be in proximity. And again, when we are doing annuloplasty devices, such as cardioband and many other devices, this can come into play. This is just one of the cases which has been reported about right coronary artery spasm or injury. Again, this may limit the use of annuloplasty devices in certain patients. The TTVR landscape is increasing widely because of these limitations with repair devices. And as you can see that there are multiple devices now on various levels of trial. from pivotal to first in man. The anchoring and sealing of many devices is different. For example, we have got particular valves such as Navigate here, which is hooks on to, not dissimilar to that of Evoke, onto the cords and the leaflet, while you have got Intrepid device on the right side, which has got tines or barbs you can think of, which grab the leaflet surface and anchor very well. The advantage of tricuspid side is that it's a low pressure system. So unlike the mitral where you really require a robust anchoring, tricuspid can be more forgiving, especially in designs like Intrepid. Evoke has the largest experience, and again, we saw the study which was presented. The other advantage is, of course, it's a percutaneous transfemoral system. It has now experience with even pacemaker leads. But the important part about Evoke is this needs to be coaxial because it really depends on all those 8 arms going under the tricuspid valve. Lux valve similarly has one of the largest experiences, and initially it was direct atrial, but now transjugular, pretty unique in terms of its fixation. And the main advantage of this valve is it's not oversized. So I feel that maybe the pacemaker rates, which we see with other tricuspid devices, will be much lower with Lux valve because the anchoring system is very different. Pacing leads usually cause a lot of issues, and when we think of pacing leads, we also think of not just implantation, but we also think of delivery of the device. It's not uncommon to sometimes have 4 different leads dancing around in the right atrium, and this can pose challenge, especially coming from transfemoral. You may get entangled during the deployment. And more critical part is we still don't understand that if the patient has existing pacing leads and we deploy a transcatheter valve, will it lead to lead fracture, lead dislodgement, and lead malfunction? So there is a lot of work which is going on at present in terms of understanding these interactions. There are certain early unique designs which are coming to address important points such as very large tricuspid annulus. It's not uncommon to see a tricuspid annulus which is nearly 6 centimeters in average diameter. Vidine is one such solution which is going to address that, hopefully. And what it has is a very large outer skirt, or outer frame, with a pericardial shelf in the between and around 30 millimeter valve in the center. This also has a pop-up effect valve which you can puncture if your RV doesn't tolerate elimination of TR. Trisol is another unique design. This tends to physiologically reduce the afterload on the RV. This is a valve which opens, as you can see in the cartoon here, in the center rather than normal other valves which open differently. So again, we will see what some of these patients do when we do cases. Some patients really come at a far end, and we have used palliative treatment. This is one of the patients where the IVC was around 4.2 centimeters, and we deployed a Z-stent, and then we deployed a Sapien 29. These patients do benefit, unlike what we thought, and even survival has been seen up to 2 or 3 years in these patients. Coming to very novel trick valve. Trick valve has, again, very large experience, and now the US trial is going to start soon. Extremely easy to deploy. It sits in the SVC and IVC, more than 300 cases, really good outcomes. And the main thing these valves do is they reduce the preload because they take care of the regurgitation going back into IVC and SVC. And that itself may have good effects, not in just terms of quality of life, etc., but maybe medical treatment acting well. And then there are some other designs which is similar or not dissimilar to Forma. This is a Croy valve which is anchored in SVC, but unlike Forma where it was just a spacer, there is going to be a small functioning valve. When we think of all these devices, we also have to think of if something doesn't work, what the next step is going to be. And I think this is going to be critical as we are learning in most devices that we don't want to burn bridges either. So I think usually the physiological question always is, at present, is reduction better than elimination. And if you can see that with tricuspid replacements, you can eliminate TR very well, but some patients may not tolerate it. With repair, you can reduce the TR for sure, but is it adequate enough? And I think this is the biggest dilemma we have in clinical practice. It's very hard to know at present which patient will actually just benefit from reduction rather than elimination. And I think slowly we are going to learn a lot about this therapy area to decide which way we should go in these patients. The main elephant in the room always is what next. And I think this is why the community, I feel, is more engaged now in the tricuspid area. We are learning more about RVPA coupling. We are learning about effects of pacemaker. We are learning about alternate ways of putting pacemaker after devices. And I think more importantly, we will see which patients benefit with which type of treatment, either a repair or a replacement or a combination of treatment, such as annuloplasty and TR devices. Thank you.
I think we have a few minutes, so let us ask the panel if they have questions or for the presenters.
Can I ask one question?
Of course, please.
Dr. Bapat. So trach valve is it seems like it's very easy procedure, but it's just device leaves TR as it is. So after procedure, pulmonary hypertension or RV dysfunction improves or not?
So we are doing the randomized trial in United States. I'm the PI. And there is a EuroTric registry that was already published. Patients with a pulmonary pressure of more than 70 are excluded. You have to have a V wave of 20 millimeters in the SVC or IVC in order to have this valve function, because the valve has to function. And most commonly, you ventricularize the atrium, meaning the atrial pressure becomes like ventricular pressure. So there's a very high pressure in the atrium. So it takes time before the atrial pressure comes down. So many people have very high BNP. They do get pain because of the phrenic nerve. And so it is a new therapy. There is some remodeling that we have seen now in the EuroTric study. So there is some remodeling that happens. But initially, it is not a treatment of tricuspid regurgitation. It decreases the congestion, and that's how you improve the renal function, preload, and once the preload is reduced, you function better. But it's a good question.
There are certain patients where nothing else can be done as well. And what we learned from early experience with SAPIEN in IVC, just SAPIEN in IVC, was ascites goes down, edema goes down, and renovascular hypertension, venous hypertension goes down. So you can manage them better on medication, although it can be viewed as a palliative treatment. But I think with TriCval and many other devices, maybe it's a therapeutic treatment. And I think we're going to learn a lot from a subset of MRI studies as well on the remodeling.
We are doing a randomized trial, so medical treatment versus TriCval in United States. So hopefully we'll start in August or September. This is our plan.
And in those kind of the patient with the pulmonary hypertension and need some remodeling, and then staged procedure like one clip, wait, additional clip, wait. Such stepwise strategy is possible?
Again, very good question. So this is the advantage of percutaneous therapy, that you can do stepwise process. So if you want to have a therapy where you don't eliminate the tricuspid regurgitation but slowly reduce it with multiple procedures, it's an idea. Again, these patients, I think the take-home message is that you should not wait for these therapies to implement the therapies until it's too late. So once you start having all these problems, this is not a great idea.
But I think you also have to take cost into consideration. If you are doing one clip today and one clip 3 months later, I think it's going to be hard. So I think yesterday we discussed cerebral protection device is expensive. And these combination treatments, combo treatments have in the past at least not worked very well. But as we get better devices, and that is why the initial feeling was that tricuspid replacement may be a good option, because there's no LVOT obstruction risk, and there is no risk in terms of embolization, it's less. But as we are doing more, we feel we have different challenges, such as pacemaker rates. Coming from IVC and deploying it perfectly can be difficult, and anticoagulation. There's a good point raised. All these patients are going to need lifelong anticoagulation. So there are different challenges in tricuspid, and we'll get a better idea by next year.
A question for Dr. Song. Echo window for tricuspid valve is more difficult than mitral valve, and it's crucial for the success of TEER of tricuspid valve. When you face poor image of T during the procedure, how do you solve the problem?
Actually, before the procedure, thank you, it's a very important question because the image is the only way to get it successful. But before the procedure, while we do a pre-procedure evaluation, we also would check only we have the very true. If we cannot have true, very clear transcatheter view, we will skip. We will not do the TEER procedure.
But are there any maneuvers which have been described, such as pressure on the chest wall?
Yes, that is also probably would be useful to improve the deep vein insertion while you play the chest wall, and you can also do the transthoracic images. That is very it can clearly demonstrate the septal and also anterior. That is the most common treatment position. And also from transcatheter view, if you cannot have very good image, do the bicuspidization. You just clip on the septal and also anterior, septal to anterior. That would be much easier to get the whole picture. But if you want to have very good Clover technique, we would definitely need very clear images. But we don't know how to do that. But our anesthesia, before the procedure, you would give some patient, you would do lidocaine jelly in the esophagus, try to expel out all the air. But so far we actually do, and also you do need a very good echocardiographer, and he can solve everything.
And also turning the patient to side. And I think the 4D eyes, at least in our situation, is a lifesaver. So if you cannot see anything, 4D eyes has become now very, very useful in these procedures.
So 3Mencio has now a plug-in where you obtain the CT of the patient, patient is supine, and you can simulate the TE views you are going to get. And I think slowly, especially in tricuspid and certain enlarged hearts, we are trying to correlate, can you predict the difficulty? And I think such systems are going to be very important because you can simulate a 40-degree probe and then see what you're going to cut in the heart. And I think this is going to be an interesting evolution.
Yes, CT is very predictive.
Yeah. We are running out of time because of the next session. So thank you, everybody, for the